All right. So again, good afternoon, good morning, wherever you are today, and welcome to today's webinar hosted by HCET. My name is Jordan. I am the Training and Community Engagement Manager at HCET, and I will be facilitating the webinar today. Let me briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. Next slide, please. This webinar does have closed captions available, and to enable them on your screen, you will just simply click Live Transcript at the bottom, then click Show Subtitle, and then you can change the settings by clicking Subtitle Settings. For more information and to keep up to date with HCET events, please be sure to follow HCET on these social media platforms and visit our website. Right, now I will quickly review some housekeeping information. So a link to complete an event evaluation will be sent to you via email following this training, and the link will also be put in the chat at the end of the training. Your feedback is greatly appreciated to help us form future events, so please fill that out for us. If you'd like to see, if you'd like to view archived presentations and a list of upcoming events, you can view these on our website. And if you have any technical difficulties during this presentation, please email us at the email on the screen, updates@hcet.org. Alrighty, to ask a question, we do encourage you to do that throughout the presentation. And to do this, we ask you to use the Q&A box. To submit a question, you simply hover over the main screen, select the Q&A icon, and then you can send a question at any time. And please make sure that if you want everyone to see your question, you can use the Q&A. If you prefer that it's sent anonymously, you can do that in there, or you can send us your questions via the chat if you can't figure out that Q&A box. And again, encourage you to send those throughout. All right, and now I will introduce you to our presenter for today's webinar, Dr. Joseph Cherabie. He is the Medical Director of the Washington University St. Louis Capacity Building Assistance Program, Associate Medical Director of the St. Louis County Sexual Health Clinic, and the Associate Medical Director of the St. Louis STI and HIV Prevention Training Center. Dr. Cherabie specializes in sexual health care with a focus on LGBTQIA+ health, STIs, and HIV, all within the lens of medical education. His research focuses on long-term complications of STIs and HIV, STI testing, STI and HIV prevention, and LGBTQIA+ population studies with respect to workplace discrimination, healthcare access, and mental health. Without further ado, I will pass things over to Dr. Cherabie to kick us off.
Thank you so much, Jordan. And I got mention in the chat that maybe the chat is disabled. So just in case we want to turn that on, I would love to be able to hear from people as well in the chat. So I heard all of the things, but first off, thanks for that introduction, and thanks for all of you coming to join us to talk about a topic that I really love talking about, which is a patient-centered approach to STI testing. Basically, we want to discuss today things such as express visits, self-collected testing, and how we can implement a patient-directed care towards providing STI testing in a way that is trauma-informed, gender-inclusive, and can meet our patients ultimately where they are at. And so testing for STIs, I think everyone can understand here, is very important. We really want to make sure that we test people in a way that works for them, but also so that we capture individuals who might have an STI that might be asymptomatic, for example, or symptomatic. And we want to make sure that we make testing work for them. We want to make it as least invasive as possible, least painful as possible. And also, we want to normalize testing. Testing for STI should be a normal part of everybody's primary care. and their regular health visits. Sexual health overall should be normalized. And so we really like to promote normalizing STI testing, and the fact that if someone does test positive for an STI, that is not a reflection on them. It is not a reflection on them failing or something to be ashamed of. It's an infection like any other, and we can test, treat, and make sure that partners get tested and treated as well. So we really, really have to work hard to try to normalize and get testing out there for our patients. And so the question is then, how can we do that in a way that works for our patients and engages our patients in their own healthcare? So I'm going to ask you all then, and you can use the chat that is newly fixed. Thank you, Jordan. So how many of you have self-collected testing implemented in your clinics already? And you could put it in the chat, just say, we have self-collected STI testing, if you could specify what type of testing you do, gonorrhea, chlamydia swabs, for example. And then do you self-test for HIV or other bacterial STIs? And I'm going to wait until I see that first answer before I move on to make sure that the chat is working. Awesome. Danny said that they have self-collected gonorrhea and chlamydia urine testing and gonorrhea and chlamydia swabs, but not self-HIV testing. Awesome. Thank you so much, Danny, for sharing. And I'm going to keep that chat open to my side so I could see you all kind of chime in as well. Same, no HIV testing. Thanks, Michelle. Awesome. And then we plan to when we open up our clinic for gonorrhea and chlamydia. Thanks so much, Amber. So I'm happy to hear that there's interest, that there is currently some element of self-testing for either gonorrhea or chlamydia at least, and possible plans to do HIV self-testing as well. So let's define things first. Self-collection or self-testing is when a patient is collecting their own samples. It could be urine or a nucleic acid amplification test swab, such as an oral pharyngeal swab or a rectal swab for gonorrhea or chlamydia. And you could also do your own HIV test, for example, as well. It can occur in a clinical setting or at an outreach testing site or at home, which means that it offers us the ability for patients to do their own testing, but also to be able to collect their own samples and possibly do so in the convenience of their own home that won't require them to come into a clinic. Home testing, on the other hand, occurs in the home setting and can involve a variety of different samples, and approved testing kits can be dropped off at a lab or mailed back. And so we're going to go through each and every type of self-collected or home testing that we could do and the various different positive things that brings, but also the challenges that we may face. And I'm just looking at the chat here because we got some more answers. Working on setting up our first programs, hoping to get information. I'm happy to be here for that. All right, no self-testing here for gonorrhea, chlamydia, or HIV. That's perfectly okay. And we have self-collecting vaginal and penile and rectal, but no oral pharyngeal swabbing and no self-collected HIV. Great. So why is self-testing something that we're talking about? Why is it something that we're interested in? Well, it's convenient for one. It's, it can easily be done. The patients can actually guide their own testing. You get rapid results a lot of the time. And so the results that are provided from self-testing actually are much more rapid than if, for example, you have to ship to a state lab, for example. Especially if it's a point of care test. Point of care test can give us answers in minutes, which is fantastic. There's less person-to-person interaction. And this is very important. We have to remember that a lot of our priority populations who we test for STIs for, so individuals that are members of the LGBTQIA population, cisgender men who have sex with cisgender men, adolescents, all of these people, oftentimes have been stigmatized, discriminated against by the healthcare system themselves, and may have had traumatic experiences with the healthcare system. So if you can decrease person-to-person interaction and allow individuals to guide their own testing, not have to disclose their gender identity, their sexual orientation, their sexual practices that oftentimes they might have been judged for, then this allows us to do so in a way that lets them guide their own testing. and allows them to feel a little bit more comfortable and possibly avoid being stigmatized or discriminated against. It is also less invasive. And so, for example, if you're doing a blind vaginal swab in individuals with a vagina compared to doing a speculum clinician-guided examination, we have to remember that many of our patients have experienced sexual assault. I've had colleagues who've had patients who have had flashbacks to their sexual assault during a speculum examination. So if they can guide their own testing, we could possibly avoid certain trauma triggers and allow them to feel more comfortable in obtaining an STI screening or an STI test. There's less shame associated with it. And again, it's more trauma informed. If a person has been a survivor of sexual assault, if a person has experienced trauma, I myself have gone to an STI clinic and disclosed the amount of sexual partners I've had in the last 6 months and been judged for it. I didn't want to go back to that clinic. So if I could have avoided that and just picked up a test kit and swabbed myself and not had to interact with anyone or deal with the judgment, trust me, I would have done that, but that wasn't an option for me. It also increases screening rates. If individuals can self-test, if they can pick up a kit and test in between clinic visits, for example, or before they go to the clinic, then that allows them to actually screen more frequently. It's less time consuming, and we'll show evidence in towards the end of what we did here in our St. Louis County Sexual Health Clinic about how express visits and self-collected testing actually sped up a lot of our clinic visits and allowed patients to choose an express visit, especially if they were asymptomatic. You can overcome certain structural barriers as well, such as most of our clinics are open from 8 to 5 at best, right? Those are also work hours, and we're open during the work days. So if you can overcome those structural barriers and allow a person to pick up a kit, for example, do their self-collected testing, and then drop it off on their way home from work or during their lunch hour, it allows them to actually test in a way that doesn't involve them taking an hour out of their day, taking time off from work and coming to get tested. You could target key priority populations, and it's useful in multiple clinic settings or at home, and you can test while waiting for or in between appointments, like I said earlier. So what are the challenges of self-testing? It sounds great. It sounds like I would love to be able to self-test everyone, but there are certain challenges. Certain self-tests that you can order online, for example, and pay out of pocket range between $100 to $300. If you just Google HIV, STI self-testing kits at home, this is usually the price range that you'll see, and it's quite expensive, especially if you're paying out of pocket and it's not going to be covered by insurance. There are also validation issues, both for self-collected and at-home testing. And so you want to make sure that the testing modality that you use are valid and that they have been FDA approved. There is still a lack of FDA clearance for certain testing modalities. And I do want to emphasize this because there are certain testing modalities that are being advertised to a wide variety of different clinics, but they have yet to be FDA approved, or we're not certain about the validation of them. If you are interested, though, the CDC does have a very neatly laid out website of all self-collecting modalities that have been FDA approved thus far. And the link will come up later. But self-collected testing for gonorrhea and chlamydia without a physical exam is traditionally intended for individuals who are asymptomatic. And so in the past, for example, in our STI clinic, we ask if a patient has any symptoms. If they don't have symptoms, then they qualify for express visits. And the reason for that is because oftentimes if someone is symptomatic, we want to try to rule out other reasons why they might be having these symptoms as well, and they may warrant a physical examination. But we also want to make sure that there is proper sampling and proper collection technique. And so we're going to talk about that in the coming slides. All of this goes back to, though, taking a good sexual history. And so if you've ever heard me give a talk before, I love this guide to taking a sexual history from the CDC's website. They've adapted the 5 Ps. And it is really important for us to take a good sexual history, because then and only then can we know what individual sexual practices are and if we need to, for example, perform extragenital site testing. So I need to know, how many sexual partners you've had in the last 3 months. How many sexual partners have you had in the last 6 months? When was your last sexual encounter? So that's the first part, talking about the partners. What are the genders of your sexual partners is also a really important question. As for sexual practices, what type of sex are you having? Are you having oral, vaginal, anal sex? What does sex mean to you? The amount of times that I have someone tell me I'm having normal sex and then they give a different answer from the last person who said they were having normal sex just goes to show that different people define sex differently. And so we need to know what particular sexual practices you are having in order to be able to know what to swab. We want to make sure to ask about any type of protection that they're using for STIs, whether it's condoms to vaccines such as HPV and hepatitis A and B vaccines, whether it is HIV pre-exposure prophylaxis, post-exposure prophylaxis. You want to know about past history of STIs, when they were tested, what they were tested for, and if they were treated, and if they had resolution of symptoms, and of course to discuss pregnancy intention in individuals who can be pregnant. All of this will inform our ability to perform the test that our patient needs, and in order to be able to possibly detect some asymptomatic carriage of certain STIs that may be hiding out in some extragenital sites. So let's talk a little bit about priority populations per the CDC for STI testing. And so cisgender men who have sex with cisgender men, the recommendation is at least annual screening for HIV, syphilis, gonorrhea, and chlamydia. The recommendation is to have more frequent, if new, sexual partners, and that could be every 3 to 6 months. And they recommend triple site nucleic acid amplification testing for gonorrhea and chlamydia specifically. So that means an oral pharyngeal, a rectal, and a urine sample. For transgender individuals, transgender women specifically have the highest rates of HIV prevalence amongst their population, which is 27.7, with 56.3% of those being African-American transgender women. And so there are low data on STIs, not shocking to many people. If you've ever looked into transgender health data, a lot of the data is very new. We have not been asking questions about gender identity for very long. It's something that has occurred within the last decade. And so again, there's not much data here, but the CDC STI treatment guidelines recommend that given the diversity of transgender individuals, their choices regarding surgical affirming procedures and hormone use, and their patterns of sexual behavior, it'll be important to assess for symptoms consistent with common STIs and to screen for asymptomatic STIs based off of their histories. The other group that we really want to try to prioritize is adolescents who age 15 to 24-year-olds who account for almost half of the 26 million new STI infections in the United States each year. So this is really important for us to prioritize this group because oftentimes there's a lot of nerves, there's a lot of discomfort. They might be worried that their parents might find out that they have an STI, or they might be billed to their parents' insurance, for example. So we really, really need to prioritize ways to meet this group where they are at and try to find out what testing works for them. So let's talk about cisgender MSM. This was a study done in 2014, basically looking at the utility of extragenital site STI testing compared to just urine testing alone. Up until this point, we were doing a lot of just urine tests for gonorrhea and chlamydia. But what this study showed was that urine testing alone will miss up to 80% of cases of gonorrhea and chlamydia in MSM. And so that is actually a very shocking statistic, if you ask me. And we know that oral pharyngeal gonorrhea, for example, is much more harder to eradicate than urogenital or rectal gonorrhea and can lead to resistance, which gonorrhea is, of course, something that we worry about with respect to antimicrobial resistance. So it is just serving to highlight the importance of extragenital site testing. And we know that STIs are usually asymptomatic and very much so in oral pharyngeal as well as rectal infections. So added to that, rectal gonorrhea or chlamydia is an indication for HIV PrEP. We know that individuals who have a history of rectal gonorrhea and chlamydia are at an increased likelihood of acquiring HIV. It's 1 in 15 MSM who have tested positive for gonorrhea, rectal gonorrhea or chlamydia within the last year will develop HIV within the next year. So that is something that we really need to prioritize within this population. Any person who has a history of rectal gonorrhea or chlamydia should be prioritized for PrEP. This is looking at transgender individuals, though, and this is by Patassi et al. In 2019. And you'll notice here, first and foremost, there is much more data on transgender women compared to transgender men. This is something that you'll see replicated in every single study that is done on transgender folks. And it is largely due to an under involvement of the transgender community, especially the trans men community. And so I do want to highlight here, though, that overall, there was a positivity rate of chlamydia of 13.1% in transgender women and gonorrhea 12.6% of tests done. That's a high positivity rate. For transgender men, it was 7.7% tested positive for chlamydia versus 10.5% tested positive for gonorrhea. But I do want to highlight the over 50 out of 53 of the cases of chlamydia in transgender women were extragenital site testing. For gonorrhea, it was 47 out of 51. That's a very high rate. And if we are just doing urine testing or urogenital testing, then we are missing a mass majority of our potential, our gonorrhea and chlamydia infections. In transgender men, the rates are very similar. For extragenital, it's 49 out of 104, and then it is 58 out of 105. So not as high as transgender women, but still high enough that we would be missing a large proportion of our chlamydia and gonorrhea infections if we were just to perform urine testing. Holy cow is right, Danny. So this is another, this was done by Bamberger et al. In 2019. And I really like this because I like graphs. Graphs are fantastic, and I'm a much more visual learner. So if you look at these graphs, it looks at the total number of cases of pharyngeal gonorrhea and chlamydia. On the top, it is looking at graph A, total number of cases of pharyngeal gonorrhea. Graph B, total number of cases of pharyngeal chlamydia. And then on the bottom C is total cases of rectal gonorrhea. And graph D is total cases of rectal chlamydia. The dark bars that you are seeing are gonorrhea and chlamydia only in the pharynx versus gonorrhea and chlamydia in the pharynx and the urogenital site, which is the light bar. What that means to say is that these dark bars are the number of cases that we would miss if we were only testing for urogenital gonorrhea and chlamydia. And that goes for the pharynx, that goes for the rectum as well. And you can see that we would miss a majority of cases, especially amongst the MSM population, if we only tested for urogenital sites. So with that in mind, let's do a case scenario. We have a 23-year-old cisgender man who has sex with cisgender men who presents for STI testing. He states that he needs to get done quickly because he has a 30-minute lunch break at work. He has never done self-collected testing before and is currently asymptomatic. Would you A, allow for self-testing with instruction, B, insist on a clinician exam, or C, tell him he needs to come back at another time? This is a chance for me to take a sip of water. You can chime in the chat. A. We have 2 votes for A. Any votes for anything else? 3 votes for A. B, an education needed. All is perfectly valid. So what I would personally do is make sure that we have instructions for self-testing and allow for self-testing for these individuals. I can tell you we have a bunch of posters. I've been to a clinic that actually had a video on repeat to teach you how to do self-collected testing. But we're going to go through what concerns individuals may have with respect to self-collected testing. And, I think we've proven up until this point that self-collected testing and extragenital site testing is very important. So how can we do that? And how can we make sure that we get that, but also allow for it to be done rapidly and not require our clinicians to do it? And so I like to call this section self-collected testing myth busting. The major things that we are worried about and the major concerns that I have heard from providers are that A, people will be lost to follow-up if we allow them to do self-testing, especially if they do self-testing at home. The patients won't like it because certain patients want to make sure that they get a good sample. And I have patients in cis, they might be asymptomatic, but they're like, I need a doctor to get, to take a look and to make sure to get a good sample for me. Clinicians won't like it because clinicians might not trust the patient's ability to obtain a proper sample. And myself being a clinician, oftentimes we like to think that we're better at doing this stuff than our patients might be. But at the same time, I'm going to show you some data that shows that patient obtained sampling is just as good as clinician stuff. So this is one of the areas where our skill might not be much better than patient-guided sampling. Patients can't collect their own samples or they can't do it correctly, and patients won't be able to interpret the results. So we're going to go through each and every one of these. This is with respect to HIV self-testing. This was actually a study that was performed internationally. And what they looked at was HIV self-testing and its ability to, if there was follow-up, and they wanted to see if this could be rolled out on an international scale. And this study actually was what led to the WHO guidance for HIV self-testing. And what you can see here is that across the board, there was decent follow-up. There was no statistically significant difference in follow-up for MSM or trans individuals. The only group where there was less follow-up was amongst female sex workers. And those female sex workers were specifically located in lower and middle income countries just due to the nature of which these testing sites were performed. But what did they use in order for follow-up? Bluetooth beacons, hotlines. I myself have taken an HIV oral quick self-test. You open the box, you take a look at it, and it gives you a bunch of information about how to interpret the results, whether it's pictures, whether it is, hey, if you test reactive, this is a hotline that you can call in order to make sure that we get you linked to care. And so there's a wide variety of ways that they could do this, but there was no statistically significant difference between the groups for follow-up. What is a Bluetooth beacon? For me, that is, I don't know. Personally, I always imagine that you open the box and there's something that just starts beeping at you. But typically, it's something that connects to your phone and allows you to connect to a program on your phone. So that's a Bluetooth beacon. But I like the more visual of the light popping and you have like 5 seconds to do the test, or it'll self-destruct or something. Now, as for patient preferences, studies have shown that female patients actually prefer self-swabbing, and MSM actually had high satisfaction with self-collected swabbing. I allow for self-collected gonorrhea and chlamydia swabs, especially rectal swabs in my patient population. It allows them to do their own test, and oftentimes, they might not feel very comfortable meeting a physician or a clinician for the first time and having to bend over, spread their cheeks, and allow me to get a swab. So this is a way for them to get sampling. And I can tell you, I have had many positive tests due to self-collected sampling. So I'm not too worried about their ability to obtain their own samples. There's also this huge fear, especially among cisgender men, about urogenital, especially urethral swab testing. I really liked that this study was called Not the Swab, Young Men's Experience with STI Testing. But genital exams for men are not typically normalized, and it fits within the heteronormative masculine constructs. And there's a giant fear of urethral swabs. Whereas, unfortunately, for cisgender women, and individuals with a vagina and a cervix, this is normalized much more frequently, right? A speculum exam, doing a pap smear is much more normalized. This is not as normalized amongst cisgender men or individuals with a penis. And I noticed that there's a chat here. I understand about self-testing, but what happens to risk reduction education and PrEP referral? Great question. We'll speak about that shortly, James. And if I don't, please do remind me at the end. I would love to chat a little bit more about that. All right. Now, self-testing works. These are from the CDC's webpage, and we know that chlamydia and gonorrhea testing amongst individuals with a vagina, actually doing a self or clinician collected vaginal swab is the recommended sample type. For gonorrhea and chlamydia testing in individuals with a penis, a first urine is recommended as the sample type. And then data indicate that performance of nucleic acid amplification swabs on self-collected rectal swabs is comparable to clinician-collected swabs. And this specimen collection strategy for rectal, chlamydia, and gonorrhea testing is highly acceptable. As for urethral versus first catch urine samples, this is a study just showing that your first catch urine samples are just as good as urethral sampling with respect to sensitivity and specificity. So again, getting a first catch urine is just as good. What about improper? So improper interpretation. There's often guides and kits, like I said, there's hotlines. And I always try to remind people that if they're doing a syphilis home test, the syphilis testing that's available at home is a treponema test. So any patient of mine that tests positive for syphilis, I oftentimes bring this up. If they test for syphilis again, and it's a lateral flow assay, or I tell them if it looks like a COVID test, I will tell them this is a treponema test and it'll always remain positive. Because we know that a treponema test can tell you if there is a history of syphilis or active syphilis, but it can't differentiate between the two, right? So it is really important to emphasize that, especially if you are using this type of syphilis testing in your kits, and inform them that if they have a history of syphilis in the past, that they may test positive on these syphilis kits. But why are pharyngeal and rectal testing important? STIs, again, don't just infect the urinary tract. We need to test people where they are having sex. I know this seems like common sense, but oftentimes we don't do this. And it all goes back to taking a good sexual history. And so again, 80% of gonorrhea and chlamydia cases in young women are asymptomatic, and we can miss cases. If we miss cases of asymptomatic cases, we know that the long-term effects of untreated gonorrhea and chlamydia, especially in the vagina, cervix, and uterus, can lead to certain complications such as infertility, scarring, infections of the fallopian tubes, for example, that may lead to higher rates of ectopic pregnancy. So it is really important that we treat asymptomatic cases, but also with oropharyngeal gonorrhea, I mentioned it before, it is more difficult to eradicate. If you do get a positive gonorrhea test in the oropharynx, it is recommended to do a test of cure in 7 to 14 days. I recommend the 14-day end as opposed to the 7-day end, because we get a lot of false positives at that 7-day. And by 14 days, oftentimes they would come back negative. And treating properly prevents antimicrobial resistance. So what has been cleared for self-collected testing? We know that the Abbott real-time has been cleared for vaginal and urine testing, Hologic vaginal and urine testing, Roche vaginal and urine testing, Binks.io, this is new. This is a point-of-care test for urine and vaginal swabs. Aptima has oral, rectal, vaginal, endocervical, and urine swabs, and the Gene Expert is oral, rectal, vaginal, endocervical, and urine swabs. I can also say that I myself have gone to the 56 Street Clinic, which we'll bring up in a bit, but they use the Gene Expert, and I can tell you that I've gotten an answer within 2 to 4 hours, which was really interesting. A brief bit about HIV self-testing, and we'll talk a little bit about PrEP when we speak about this. So the only FDA-approved self-test is the OraQuick in-home test. This is available over the counter. It was approved in 2012, and it is approved for individuals who are 17 or older. It's a third-generation HIV test. So what that means is that there's a window period of 21 days from time of infection till this test will be reactive. And so if it was a recent exposure, you might miss an acute HIV infection on this test. However, it contains an oral swab that is swabbed over the upper and lower gums. The swab is placed in the developer solution, and the results will be within 20 minutes. You can see here that there is information within English and Spanish, which is fantastic, and it is very easy to interpret. So these are the instructions, read the directions, open the tube, open the test kit. And luckily for us, kind of unfortunately, luckily for us, with COVID testing being what it is, many people are much more familiar at interpreting lateral flow assays than they were before. And so this is an unintended positive thing that came out of the COVID pandemic. But nonetheless, this allows us to a little bit more familiarity in how to interpret a lot of these results. And then if the test is not, I do want to highlight, if the test does not work or the results are unclear, the Oral Quick Support Center is available 24/7. So it's available for purchase in retail locations. It's also available at websites such as takemehome.org and prevention and testing organizations here in Missouri, where I work, for example. Technically, the same test is used by testing organizations for an individual to perform the test themselves. And there's a 24-hour call center. But again, there is that window period that we discussed, and it is important for people to know that. We don't recommend for PrEP HIV testing at home. We don't recommend using this. We recommend using a 4th generation test, which is more capable of detecting more rapid an acute HIV infection. That having been said, I think it was brought up by James very clearly that we really want to discuss risk reduction. We want to be able to discuss PrEP referral if patients meet the indications for this. And I think that this is a great way to make sure that we normalize testing on a regular basis in order for people to feel more comfortable. A lot of these testing kits as well can be picked up from your local health department. We know that during COVID, a lot of health departments were actually doing these take-home kits, and then they would have them bring them back. That automatically guarantees that there will be some interaction between the health department system and the individual, especially with interpretation of the test results. So while self-testing is great, again, there is this gap in communication, right? There is this gap in linkage to care. If you are allowing people, though, to take tests home and drop them off at your own labs or your own health departments, then this may be a way to ensure a little bit more that they might have that interaction with the healthcare system and the linkage to care, as well as the opportunity for risk reduction counseling and education. You know, even if that just means someone calling them to have a discussion with them about what their results mean, having a PrEP navigator discuss with them if they're interested in PrEP, and that's something really important. So I agree. The sensitivity, just real quickly about the oral quick test, is estimated to be around 92%. That is one false negative expected out of every 12 tests. The specificity is much higher, though. So again, ruling in is much higher. It's a 99.98%. That's one false positive expected out of 5,000 tests. And so the sensitivity is impacted by the collection technique and not following the instructions, and eating, drinking, or smoking before the collection. So the benefits are that, you know, you will be able to purchase a test in a retail setting, and it helps to normalize HIV testing. COVID has significantly reduced our ability to do HIV testing through outreach and through our clinics. And so this allows for increased access to testing, especially in rural areas. If they can order this online, that's fantastic, right? And we should be promoting people's ability to obtain tests, even in areas that might not be as well equipped. You can overcome stigma related to HIV testing, and not everybody wants to walk into a health department for HIV and STI testing or be tested at an outreach event. We have to also remember that a lot of, you know, I can speak for myself. I am a member of the LGBTQIA+ community. I work within this community, and for me to get testing, I would be interacting with a lot of my colleagues, a lot of people that I know within the community, because oftentimes some of these outreach events or some of these clinics are staffed by people from my community that I already know. And so self-testing for me is a great opportunity for me to, you know, if I don't necessarily want people in my community to know everything about my sex life, this is an opportunity for me to be able to obtain testing. And so I have self-tested before, and I'm a huge proponent of it. The concerns, though, of course, are the sensitivity, with the potential for false negative being quite concerning. So again, having that discussion with people to discuss, hey, if there was a recent encounter that you were worried about, then or a recent exposure to HIV, then we need to do a different formulation of testing, such as a 4th generation test. What happens when a test is reactive? How do we ensure confirmatory testing, partner services, and linkage to care? I think this is a concern for many of us. For those of us working in the traditional testing programs, this feels a little bit worrisome. It makes us a little bit anxious. And then cost at retail, again, this cost, the oral quick test itself costs $40. Public health wholesale is $26, but traditional rapid test costs $5 to $10, not including staff time. So in what other ways can we be more patient-centered? You know, how this goes back to asking our patients what they would like and meeting them where they are at. So, we know that individuals with vagina prefer vaginal self-collected swabs. We can ask individuals where they would like to be tested, where they feel more comfortable being tested, at home, whether it's at pharmacies, whether it's at emergency departments. But I can tell you the majority of people feel a little bit more comfortable in their home setting compared to going to and interacting with the healthcare setting, especially if, again, they are a minority or previously marginalized population. So what about express visits, PrEP and PEP services, and telehealth? Well, like I said, there are express clinics for STIs. I mentioned the Dean Street Clinic before. This is in central London. I myself have gone to this clinic when I lived in London. It is as fancy as that looks. And you do your own self-collected swabs. They send you down like this tube, which is kind of like the bank teller tubes that go to the lab. And so they teach you how to do your own swabs, and then you go down and you get a point of care HIV test, as well as blood drawn for syphilis and hepatitis testing. The results are sent to your cell phone within 4 hours of you getting of you having the test. And so they do warn you that you will be receiving STI testing results on your cell phone. So please be aware and make sure your phone is not within view of anybody. But automatically, if someone has a reactive test, they are booked onto they are booked into the clinic to receive treatment and have a clinician evaluation. And so it is wonderful. It does have its flaws. It's quite expensive to do and quite expensive to upkeep. But what I will say is that it is a patient-centered approach, and I didn't have to interact or speak with anyone until I got my blood drawn, which was pretty fantastic. So again, if you want to learn more, please look up the 56 Dean Street Clinic. But it's very hard to emulate here, especially with not clear funding mechanisms. And then there is a question: do they book those before the results come back or after? They book them automatic. So when you are putting in your information, they will automatically reflex a booking to your results. So if there is a reactive test, then you will automatically be sent to the booking terminal, and they will have a linkage to care person call you just to make sure that you get an appointment. Great question. So then let's talk about STI Express Visits. Let's say you don't feel necessarily comfortable having patients take their testing home, and you're worried about the linkage to care element. How can we make our visits in our clinics more patient-centered and more rapid? So this is it's a triage-based STI testing without a full clinical examination is what an STI Express Visit is. And there's no one size fits all. So there are variable patient flows that exist. And again, if you want more information on this, the NACHO website listed below is very helpful. But what we allow for, and we have express visits in our St. Louis County Sexual Health Clinic, we actually triage based off of whether they are symptomatic or not. And staffing models allow for healthcare professionals to operate at the top of their licenses. So, and patient self-collection is prioritized with ideally some element of technology and automation. But basically, we try to have our MAs do an interview to make sure that a patient is asymptomatic. If they are asymptomatic, then we allow them to have express visits if this is something that they would like. If they insist on having a clinician exam, then we will, of course, do a clinician exam. And now we have even pushed forth with the with all of the advances that we have tried to do with respect to COVID. We have allowed people to do this triage-based mechanism using an iPad at the front of our clinic, so that they don't even have to interact on a person-to-person interview level. Actually, they can just fill out their respective symptoms that they're experiencing, what they would like to be tested for, and if they would like a clinician exam or an express visit straight from the get-go. So you can do, like I just said, an automated check-in system, a non-provider visit with self-collected testing. Oftentimes our MAs go over how to perform self-collected testing, but we also do have posters in our clinic that does show how to obtain proper self-collected testing for an oral, pharyngeal, and rectal swab. Rapid test results are available to patients, and usually we could do that rapid HIV test that will give us a result within 20 minutes. And automated delivery of test results to patients is ideal. So let's talk about STI care in 2022. We have fewer STI clinics than 20 years ago, with declining public health dollars and services. And we know that our services were extremely strained during COVID, with a lot of clinics not being able to remain open. We were one of the few clinics within the St. Louis County region that actually remained open throughout the pandemic, and it was very hard for us to stay open. And so this is really an important way to try to increase the, we know that there are record rates of STIs across the board. And so how can we make sure to not overwhelm our STI clinics that are already overwhelmed? And how can we make a patient flow that works and gets more patients through the door and out the door, allows us to detect more asymptomatic cases, and does not overwhelm our staff? So it takes a little bit of innovation. But what I will say is that this was a study done through the CDC that showed that between February and November 2020, many clinics adopted telemedicine services and many fewer adopted offsite and HIV STI testing. So STI self-testing visits, you can see a slight bit more was offered, but telemedicine services were massively increased, and then off-site self-testing for STI and HIV services increased as well. So the NACHO website does have information on implementing Express STI services, and again, this is considerations and lessons learned in 2021. These are the various different sites that they surveyed. I will say that in our work with the Prevention Training Center, we went up to Howard Brown Health, as soon as we could with pandemic restrictions, and we saw their ability to provide offsite STI and HIV testing, and it was pretty impressive. So again, this is a great resource if you are looking, and it goes through the lessons learned and possible areas of improvement. So the question is, are express visits for STI care a missed opportunity for patients? I think yes, actually. I think that they should be increasingly used. The percentage of the visits, of course, varies with time. You don't have a gram stain that is performed. I will say we traditionally during our clinician guided visits, we will perform a gram stain, and that gives us rapid results as well. Oftentimes you might not be able to provide treatment during that visit, and there's limited staff contact, but it allows for more patients to be seen. It allows us to test people more rapidly. It allows us to test people more frequently. It allows us to detect asymptomatic cases more rapidly. And I will say that there are positives, there are pros and cons in everything. So there is a question in the Q&A that says, our obstacle is getting approval from a conservative county board. Any suggestions for this situation? Yes, I right there with you, living in Missouri. So the way that you could do this is, it's hard. I know that this, I know who I'm speaking to here, and I know the world that we live in right now of alternative facts, but if you show them the uptake increase, if you show them the amount of extragenital site testing that we would detect in this, if you show them the facts and statistics and stick to that, and show them the possible time cost sharing, the time cost saving that will be done by implementing this, then I think it would be convincing. And so again, NACHO has great resources with respect to this, and NACHO is an organization of community health organizations, and so they are also always willing to help. We also have another question. We use Aptima swabs, so they are approved for oral swabbing. However, our lab is through the state and they will not run oral swab submissions. Do you have any recommendations on guidance on how to suggest we start oral swabbing? I would just emphasize, I would recommend and discuss with the state. This is not the first time we've heard this from states before. I would recommend that very clearly oropharyngeal, especially gonorrhea and chlamydia swabbing, is very important to detect. It can increase the rate of antimicrobial resistance and allow for further spread of disease. So trying to emphasize and pointing out that the fact that if you do oropharyngeal swabs, that, and again, all of these studies are available at your disposal, having that open discussion with your state labs about the importance for these tests is important. And oftentimes, you know, I know the struggle is real. I have been through the struggle myself, but it is oftentimes it's hard to argue against actual scientific facts and data. And so trying your best to push for it as much as possible. And money talks as well. So if you could do a cost benefit analysis, that might be very, very helpful. So yeah, it's male trick test. Yep, I'm with you. We have issues ourselves too. So again, we are not perfect. I work in St. Louis County, so we have our restrictions as well. But again, with the way things are moving and with the data that has been shown that this is beneficial, then I think we need to push to move this in the right direction. And again, your NACCHO representatives are very helpful in this, and they are huge advocates for a lot of this, a lot of these workflows and trying to implement express visits. So if you need any contacts with respect to that, I'm more than happy to provide. This is just an example of a workflow. If, you know, looking through an algorithm of a person doing an express visit, you know, if they're established patient, yes. Does the patient have symptoms? No. And then allow the patient to check in. Nurse practitioner calls the patient, updates ambulatory organizer. We do the quick check, and then you do self-collected swabs. You ask them to wait in the waiting room until their HIV test is resulted. And then basically you allow them to check out and say that we will follow up with any positive results. So motivations for express visits: it reduces turnaways, reduces clinic clog, gains staffing efficiencies, and reduced test turnaround time. It addresses stigma and increases testing amongst priority populations. So this was a study also done by NACCHO that says, do express visits help? And so there was a higher average number of non-express visits per day than express visits in the express time period. So express visits, there were 23 versus 47. But basically, they did show that they were able to see a lot of people with express visits. I think I'm missing, I may have jumbled some of my slides, I apologize, but this is just looking at whether express visits were beneficial. Again, same study, but you can see that their overall visit satisfaction was higher amongst express visits. Waiting time was way better. Service unmet needs was higher, and self-collection comfort was higher. And so across the board, you see that there is an improvement in satisfaction with STI clinic visits with express visits compared to non-express visits. Do they save time? Yes, this was the slide I was looking for. And so minutes between arrival and departure, you could see it's 81 minutes versus 173 minutes for non-express visits. Minutes between arrival and phlebotomy, 69 versus 82 minutes. And then minutes between phlebotomy and departure, 29 minutes versus 125 minutes. So it saves a lot of time is the answer. It's in the title, it's express visit. This is our own data from St. Louis County Sexual Health Clinic. Average total duration of patient visits for express visits was 58 minutes versus 79 minutes, and EMR record review was 41 minutes versus 64 minutes. And so under an hour versus an hour plus for express versus regular visits. And this was the workflow that we did within the St. Louis County Clinic through our EMR system. And you can see that it allowed us to, this is the clinician visit. And the biggest time restraint is being placed in a room, seen by a provider, the gram stain, the blood draw. But that decreased when we actually went through our express visits. And so do express visits affect care? package STI testing rates and express versus non-express visits, you can see that there are higher rates for chlamydia, gonorrhea, syphilis, and HIV testing. And our express visits targeting patients without symptoms, the positivity for chlamydia, gonorrhea, syphilis, and HIV was lower amongst express patients compared to non-express patients. And what that means is that we were mainly testing asymptomatic cases. We expect a lower rate, right? So this isn't to say that this is less effective, but we are capturing asymptomatic people, which is pretty fantastic. And we wouldn't be able to capture them otherwise. Fewer express patients were treated, though, for chlamydia and gonorrhea than non-express patients. Again, we do know this, though. We know that if there's a gap between the results and them being able to receive treatment, that there might be less uptake. But because patients that were non-express might be able to be treated then and there, and them being symptomatic, they're more likely to receive treatment. But I wouldn't say that this is a convincing factor for not doing express visits, because the average number of days between STI testing results was higher for express patients compared to non-express patients at 3 days, 2.8 days, and 2.3 days, and 2.1 respective for chlamydia, gonorrhea, syphilis, and HIV. Non-express, again, this is going to, a lot of the results will be available in person. So this might explain why there is a little bit of a delay in testing with express visits. But again, we are testing asymptomatic folks, and we are testing people who have a rapid lifestyle. So I don't want you to take these results and say, oh, this is worse. This is actually testing that wouldn't be able to be done otherwise. And our goal is to make sure that you have to have a plan for express visits to have STIs, regardless of whether they are symptomatic or not. Great question. So has anyone started offering express STI testing services at first monkeypox vaccination? That's a great thought process. We're trying to find ways to integrate monkeypox testing for monkeypox cases with STI testing, but also I think that's a great opportunity for individuals who are showing up for screening to possibly get vaccinated as well, or doing express STI screening for individuals who are being vaccinated. I think that's a wonderful idea. We know that there are I can't say it enough. I think that's a great idea. And I think that any person who's coming into the clinic, you should take advantage and offer STI screening if they would like so. So if an express patient has an STI, chlamydia, you can call in the treatment or provide medications. Gonorrhea, need to present for ceftriaxone, which is a little bit of a barrier and a little bit of a limit. For syphilis, they need to return for an exam and determination of treatment course. And HIV, you need to request the patient to return to the clinic for counseling and linkage to care. So again, it is important that when you're creating this plan for express visits to have a plan for each individual if they have a positive result. Again, where they intersect is going to be treatment, prevention, counseling, and partner services as well. And so you want to make sure to try to design express visits for success. And so express visits allows for a little bit more prep counseling, actually, because you have more time in the clinic visit. So patients provided prep counseling was 27% in express visits compared to non-express visits. Versus patients who were currently on PrEP, 7% versus 16% for express versus non-express. I can tell you, I work in a very, very busy STI clinic. If I have spare time, if I have 20 patients coming in and out, it's very difficult for me to go through PrEP counseling. If you have more time and have more staff availability and have the wait time for that HIV test, for example, and they can discuss PrEP, that's a great opportunity to do so. So I think this is further proof that actually we can integrate it into our services and integrate PrEP care into our services through express visits as well. These are nature resources, again, express STI services to increase clinic capacity, implementing express STI services, and fact sheets for billing, especially for express STI services. And then this is our own website for the Prevention Training Center. It's STDCCN. If you have any clinical questions with respect to chlamydia, gonorrhea, syphilis, HIV treatment, anything STI or HIV related, monkeypox even, please use STDCCN. Your local prevention training center will respond within the time allocated and provide you with any answers. We get a lot of really great questions. And so please, please, please understand that this resource is available for free. But also, if you ever want to request any new technical assistance for your respective clinics, that is also available through CCN. It is important to give feedback, of course, and tell us how we are doing, but I do want to thank you all. This is our Prevention Training Center website, and I am going to stop sharing and allow for questions. Thank you, Andrew. That's very nice. And then I'm just reading Danny's comment, just thinking they have to come back for a second vaccination. So they will come out. Yep, exactly. So what I can say about STI services in general, if you can take home one point, right? Integration of services is important. And what I mean by that is HIV testing, bacterial STI screening with chlamydia, gonorrhea, syphilis, packaging these together, making sure that if we're testing for one, we're testing for all. Making sure that if you're doing at home, if you're doing testing kits where people can send home, that they have the information of how to bring it back, and making sure that the process works, making sure you have a mechanism to report back testing, especially for express visits or testing that is brought back into your clinic. Making sure that if it's a mail-in thing, making sure it's stable, especially in the heat. I can tell you Missouri heat, very bad. So you want to make sure that they know to send these up. But all of this is to say that there's a lot of stuff that needs to be considered, and NACCHO has great resources to look this up if this is something that you are interested in. They have the toolkits, they have all of this stuff. And so we know that this works. Please feel free to use any of the statistics that I just shared with your respective legislatures or your county executive office or whatever. But we know this works, and we know that there are still things that we need to work out. It's not a perfect system, but there never is a perfect system in public health. But this is a way to save time, hopefully save some money, and increase access to testing, especially when we're seeing, I mean, you could just point to the rates by the CDC. Even in the pandemic, we were seeing an increase in bacterial STIs. And so this is how we can make sure to test more people and meet them where they are at.
Thank you so much, Dr. Cherabie. We do have a while for if folks have questions. This does go to 12:30. We can definitely, or 1:30, depending where you are. We can end early, but I do want to give folks the opportunity to come off of mute and ask questions. I know a couple of hands went up during the presentation. So if you do have a question and you'd like to come off of mute, I can give you that ability, but just raise your hand if you'd like, or you can put your questions in the chat.
I'm just scrolling through the chat as well, just to see if there were any questions that I failed to answer. And I just want to highlight the, with respect, because I know a lot of people had mentioned the lack of self-collected HIV testing. There are, so we're trying to utilize a lot more of our 4th generation point of care tests. And again, that gives you an answer of, I mean, within a window period of 10 to 14 days after exposure. That test is also what is currently recommended in the PrEP treatment guidelines right now, especially to start PrEP. If you get a negative 4th or non-reactive 4th generation test, that means that you can start PrEP, which is fantastic. So you can even consider integrating that into your same-day PrEP starts, if that is something that is of interest within your clinic. That's what we are doing in the St. Louis County Clinic. We are using, we're going to start utilizing our 4th generation and then send our 4th generation, of course, to our state health department. But it allows us to do a same-day prep start and send people home even with starter packs of generic Truvada, for example. And so integration is what's the name of the game in this scenario. And so trying to figure out what works for your patients and what works best for your clinic flows is going to be important.
Thank you. And while folks are still thinking, if they have any questions, I'm going to go ahead and put the evaluation to this training in the chat. Again, this link will be sent to you via email following the webinar as well. And there will be a link to view the recording of this webinar as well.
Recommendation for which point of care machine test would be best. All right, I'm just reading Amber's question. And so the best point of care, so I would go to the CDC's website of approved point of care machines with respect to testing and figuring out which works best within your budget, basically. We don't want you to have a point of care test or anything like that that might not be able to be sustained within your budgets. And I understand the stretch of a budget. So it is important for you to, there are options available and there are new options being added each day. And there's going to be an upcoming, if I remember correctly, a CDC report that's being worked on right now with respect to modalities for self-collected testing. And so keep a lookout for that, but try to figure out which one works best for you. And also open discussions with the state. I know. I work in a Republican legislature as well. It's very difficult sometimes, but nonetheless, it is, you might be able to get stuff done with joint collaboration. Do you know any universities that have implemented self-STI testing? I think students would be far more open to this kind of, I can look it up. I'm not sure. I don't know if there's a list for sure. And we work closely with our student health services here at Washington University. And they are proponents of self-collected testing, but I agree, if there's availability, there are also opportunities for within the, there are certain organizations that are trying to utilize and trying to prioritize and target these student populations in order to do mail-in test kits as well. So might be worth looking at, but yeah, working with your local university and trying to see if they'd be willing to do it. I think it's a great opportunity. Our office uses biolytical and Sti HIV antibody tests and have had great experiences. Do you still recommend that we keep some 4th gen? Yes, 4th gen tests are great, especially for confirmatory testing. And it's useful in order to make sure, especially if you want to start a patient on PrEP. I'm not, is the biolytical, just clarification, because I'm not familiar with it off the top of my head, is that a 3rd generation? Yes, so it's perfectly fine to use a 3rd generation, just understanding that the window period for a 3rd generation might still allow for that. It might go out to 17 to 21 days. But the recommendations for PrEP starts especially is to do a 4th generation test, and it allows you to detect more acute HIV more rapidly. Great questions. Any other questions?
All right. Doesn't seem like there's any other questions, but again, thank you all so much for attending this webinar. If you do have any other questions, Dr. Cherabie did just put his email address in the chat. Thank you so much. So feel free to use that. And again, please fill out that eval for us. We greatly appreciate the feedback. And I hope you all have an awesome rest of your day. And thank you, Dr. Cherabie, for a wonderful presentation.
Thank you for having me. Thanks,
Bye, everybody.